Peace and welcome to the Why Midwifery podcast. I am your host, Dr. Teah Hairston, and I have been a birth worker for the past 4 years. And I'm super thrilled to have part two of our discussion on why midwifery with our special guest, Nurse Midwife Lisa Davis. Hello again, Miss Lisa. We had a phenomenal conversation last time, and we want to continue that. So, if you will, can you discuss a little bit or explain a little bit about the midwifery model of care?
The midwifery model of care is a care model based on honoring a woman's body, actually, and really respecting um, the physiology of the body, and that it can do what it's supposed to do. And so, um, a midwife wants to do as little intervention as possible and allowing her body to birth.
Oh, so
And
that's it?
that's pretty much the summary of the basic midwifery model.
Okay.
Is
Wow.
is to support and to care for the women that are birthing, um, the birthing babies, and to do as little intervention as possible.
Yeah. I love
And
that.
that,
I really do.
yeah.
Okay. So, can you talk about the types of care you offer? Perinatal, intrapartum, postpartum care.
Yeah.
Can you talk about that?
So most women come into my care at around 12 to 15 weeks. Usually that's the second trimester. Um, and usually by then they've confirmed their pregnancy. They've gone to a provider. Maybe they may or may not have seen an OBGYN by then, or a midwife in the hospital, but you have usually gotten lab work done. Um, and and so when they come into my care, or I can get their lab work done. They just need to, blood count and medical history, and um, does and so if they have any health history problems or anything like that. Um, Usually around the 15th week, they are doing genetic testing to see if there's any genetic disorders, like cystic fibrosis or anything of that nature. Um, and how they come up to my care is usually we have a consultation. I tell them all about my services that I offer. And if they decide, I send them a contract and they make a deposit. And then I send them a link to my electronic charting system where they fill out a health questionnaire and an intake form. And then we schedule our initial appointment. Um, we go over their health. We do head to toe assessment. Um, and we don't just focus on the physical. It's mind, body, spirit. So I really want to know, how's your spirit? I want to know, how'd your day go? I want to know what you eat today, and I really want to, and then I go into in-depth discussions about those things.
Mhm.
Um, and how's your relationship going, kind of thing. And we talk about what birth means to you and what kind of birth are you envisioning. And my goal in prenatal care, other than establishing a relationship and trust, and really really getting to know my client and having them get to know me, is to let them know that I'm here for their safety. That's I consider that to be my primary goal, is that they remain safe. In the event that it is no longer safe to be in my care, then I'm suggesting that we transfer you to someone whose care you will be safe in.
Mhm. This,
And so the schedule of the appointments, it looks like like in the hospital. scheduled appointments, meaning, every month up until you're like, uh, every month until you're like 28 weeks, every other week until you're 36 weeks, and then every week until you have the baby. Um, in home birth, it's against the law for us to do home birth past 42 weeks.
Mm.
So, um, there are things that we can do that I won't get into that can if they're approaching that 42 week to help their labor along. But I won't do any intervention unless they want it and unless we're approaching that 42 weeks. Um, and that's pretty much what it looks like. It looks like, like what you would do if you went into the clinic. You do, you get your blood pressure drawn, you get your baby measured, you get your baby listened to, and then other stuff, right? And which makes, and I am like, we're not leaving the appointment until all of your questions are answered to your satisfaction. And then, so sometimes, an appointment could last an hour and a half. So, and so that's what prenatal care looks like. And I was working with a student. She just relocated, so I don't currently have a student. But the team looks like, I highly encourage my clients to get a doula for labor support, especially if it's their first baby. And so they're part of that team. And then I work with other midwives in the community as birth assistants. So typically there will be 4 people besides the clients and their family members that know birth or familiar with birth. And so in the intrapartum, it kind of looks like the doula getting there early on to support them until she transitions into active labor, and then I show up with the student, and then when she's transitioning into getting ready to have the baby, that's when the birth assistant shows up. And then our postpartum visits look like so after she has the baby, well, just to back it up, we typically stay there after the baby's born until everyone's stable, which on average lasts about 4 hours. And because we're only there for 4 hours, we come back often. And so the visits look like 24-hour visits. So one day after the baby's born, and we come back on day 3. We come back at 1 week, 2 weeks, 4 weeks, and 6 weeks for postpartum
The whole
visits.
team?
No, just
When you say
typically me and the midwifery student.
Okay.
It'll be just me or just me and the midwifery student. Everybody else was for the birth. The doula, like if she has a doula, they typically do separate visits. If she has, some women only hire postpartum doulas, or some women hire doulas just for the birth. But if she is a full spectrum doula, then she will. They vary, they range, but usually about 3 visits postpartum.
Okay. And if you will, talk more about safety, because you made a comment a little while ago about making sure that they are safe, that the women are safe, that their deliveries are safe. So can you talk more about why midwifery care is safe?
Okay. So midwifery care can be just as safe, if not safer, than hospital care. And I say that because it's because we do a lot of preventative work, right? So I am really cognizant of the fact that the most common complication in pregnancy is hemorrhage. One of the most common complications in labor is hemorrhage. if they bleed a lot, right? And so I'm in my prenatal care doing so many things to mitigate that factor. Like, I want your blood volume to be really good. I want your hemoglobin, I want your iron levels, I want your platelet levels to be really good. I want them, all of those things to be really good. And I think the hospital can afford to really not be on you about that, because the blood bank is right downstairs and there's an iron infusion that they can give you, to fix that, that problem at the last minute if it's still a problem. I don't have that luxury. And so I want to take care of the problem early on. And so we are talking about plant-based iron. We are talking about, iron-rich foods. We're talking about foods that build your blood. We're talking about, low stress, and we're talking about ways, low salt diets. We're talking about high protein diets. And all of those things are so, 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 so very important in a healthy pregnancy that contribute to you having a nice, safe birth, you know? And so people, I know for sure that the medical industry underestimates the value and the role that good nutrition plays in outcomes. And so that's something that, when I'm like, you are a good home birth candidate. A good home birth candidate is heeding the nutritional advice, because that's one of the things that helps you to have a safe pregnancy. So, all of that said, so there are genetic factors, there are other things. So we're doing blood pressure checks, and we're doing, you're checking your urine and all of those things. Um, um, and in the event that you develop some, common pregnancy disorders such as preeclampsia, we're sending you to the lab, to the triage and labor and delivery to get checked, or we're sending you to the lab to get blood work done, or all of those things.
Mm-hmm.
So all of that contributes to, a safe birth. And I just want to say that a lot of times in the hospital, they have this, continuous monitoring that gives the illusion of a safe birth. And they will tell you have to be continuously monitored, but we all know, and they know, that the studies say that those do not make birth safer. It does not make the outcomes better. It actually increases the C-section rate and all the complications that comes with having to do unnecessary C-sections. So, and so, we do the standard of care, which is intermittent monitoring with a Doppler, and it keeps you safe. Yeah. You can still monitor the baby and still know when the baby's not doing well if you monitor with a Doppler. So there's not really a whole lot of need when you have healthy pregnancy for continuous monitoring. Yeah. And so that, so those are the things.
So can you discuss perhaps if there are challenges to having birth take place outside of the hospital?
There are challenges. There are, there's a lot of different belief systems out there, right? So, and then there's a lot of different trust factors out there. So some of the challenges can be that you can come across a client who is so anti-hospital that even when you suggest that she goes, she's like refusing to go. And so you're in the ethical dilemma of abandoning her when she's probably needs you the most versus, her having a safer birth in a hospital environment. And so that can be a challenge. And I know that it hasn't really been a challenge for me, because I really talk a lot about, you know, um, if I really feel like if there's a need to go, then we should go. I'm actually seeking that type of client who is willing to go if I say it's necessary. But it has been a challenge for a lot of midwives who want to serve um, people who are very, and I totally get it. Like, I understand why they wouldn't want to go to the hospital, and then some people are just willing to they're willing to, I want to say, um, there can be consequences to not, getting the higher level of care. And some people are, just like kind of a Jehovah Witness doesn't want blood no matter what, and they're willing to die for it. It can be the same thing in birth. There are women, there are people, there are families, there are belief systems who, like, well, this is, if God wills it, then God wills it. If something bad happens, something bad happens. And I'm not just Jehovah Witness. I'm not picking on any particular type of people, but I know that, like, the Amish have that belief as well. They don't do hospitals no matter what. And if they die, it's God's will. So and there are midwives who have been called to work with that population. It's very hard. When you see that, they could actually benefit from hospital care, but they refuse to go. So I think that's challenging. I think that's very challenging. And uh, the other challenge is, like, I really like to work on birth plans and creating energy in the room, and we want to have an energy that doesn't bring in fear. There's no reason to be scared of birth. There's no reason to be scared of the intensity of the contractions that you're going to have. And so I really try to work with families. We have birth team meetings that we try to answer questions of family members, because sometimes it's not just the client. It's not the client that has a problem with the home birth situation. It's their family members, and then if they can bring in the spirit of, you really should be going to the hospital. You really should go to the hospital, and that it really doesn't help the whole situation, and can be and can bring a different type of energy into the room where somebody's really scared and the other person is trying to alleviate that fear.
Mm-hmm.
And so I try to alleviate those fears before we actually get to the birth process.
Yeah, definitely. So, can you share about African-centered midwifery care? We haven't talked about that.
Yeah. So, but basically, African centered is just centering people of African descent, and really being culturally, you can say culturally aware. You can use those buzzwords, culturally competent. But I'm Black, and so I know Black people, right? I'm not saying we're a monolith, because we're definitely not. But I was raised, in a Black family, and we practice a lot of black quote unquote Black traditions. And so part of that being African centered is just being aware of our culture. And then but also it's a reclaiming of African traditions that were stripped from us when we were enslaved and brought to this continent. And so so I am still learning a lot about African traditions, and the things that helped them create their communities. The and one of the biggest things is the importance of community. So in African traditions, it's not just I say mind, body, spirit. We all know family, but then there's community. So there's a lot of us will leave out the community, and we may have community in the church, if that's your belief, but not everyone has that belief system. But and so if you don't have that, it's about creating your community. And so I talk a lot about um, the importance of community, and how in the American culture we have been brought up to be individuals, and to do it all on our own. And we already know about the strong Black woman, because she's supposed to be able to do it all by herself. And that's killing us, basically. So I really talk a lot about letting that go and embracing people who want to help you,
Mhm.
and accepting the help and asking for the help, because the hardest thing that we have is asking for help is so, so hard. So I really, really encourage um, my families to ask for help, and that people will say, what you need, can I help you? And then the conversation will end at that, because that person really doesn't know how to help, because we've been separated from our traditions. And so the person wants to help, but they don't really know how. And then you need the help, but you are really too prideful to ask. And so if you can let that go, and then you can direct the person who wants to help exactly how they should help you, then everyone is getting their needs met. The person feels really good about helping, and then you feel really great, because you don't have to do it all. And we can't do it all. Like, we just can't. And postpartum depression is through the roof, because we can't do it all. We have issues in health, and our blood pressure is through the roof, because we can't do it all. And so part of being African centered is reclaiming community, reclaiming uh, herbal traditions, plant based medicine, uh, medicine as food, food as medicine, um, and really, really taking care of our women once they have the baby, um, knowing that they don't have to do anything but breastfeed the baby, and take care of their personal hygiene. And everything else, they should be served food, give them massages if they need it. They should not be doing any type of housework, or no laundry, no dishes, no cooking. Like, if if they get that, and they can do that, if I get them to do that for 2 to 3 weeks, I count it a success. But I really am going for the whole 6 weeks, because in the African tradition, we don't. The woman is cared for 40 days. They don't even go outside for 40 days, and everyone serves them. And so, if we can reclaim that, in those countries, postpartum depression is unheard of. So
Uh, yeah,
that's what it means to me.
that's really powerful. And when you talked about, we can't do it by ourselves, um, it resonated with me, because we're not supposed to have to do it by ourselves, right? Like you
Right.
said, we come from communal people. We believe in the
Right.
collective, um, and it's because we've been brought to this world or this nation, and we've been there. The colonized way of thinking, or the Western way of thinking, has been ingrained into us, and so a lot of our traditions have been lost,
Right.
erased, right? And so I'm really excited to hear you talk about this African centered model and bringing community back into it. And I'm wondering, where are you studying? Because you said you're still learning about African centered midwifery care and how to
There
incorporate
I
that.
am. Um, I believe in Black liberation, and I believe, in like our history, like Black Panther movement, that kind of thing, where like there was these 10 commandments. There were things that were laid out of things that Black people need, right? We need access to quality care, and so a lot of my teachers and mentors have been people who believe along those lines, and then some of my heroes in midwifery is like Mama Shafia Monroe, who taught me a lot about African centered care and food. Um, Jenny Jones, Makeda Kamara. Um, I can go on. We have some amazing grand midwives that have been doing this work forever, and have really blazed a trail for us to come through and do what we're doing right now. And so I really those are the people that I'm learning from. People who are in Africa right now, and who are on the ground with very experienced midwives there, and who are learning from them.
Wonderful. Thank you so much, Miss Lisa, again for joining us. And thank you so much for watching our Why Midwifery podcast. Stay tuned for future episodes and take care.
Thank you.